Thank you, Dr. Lee. Good morning, everyone. It's my great pleasure to be here and honor too, and sharing that experience. For a long time, that the many friends of mine here, I really feel at home. And the first topic I want to present to you is that a really simple one. Let me start with this program. This is the agenda of this session. The plain film first, and then echo and CT and MRI. It's a little bit misleading. Why? Actually, that you do the echocardiography first, and then later you do CT or MRI, or if you have some time, and then take the plain film. So in that regard, questions to be answered from chest radiographs are actually the heart size and pulmonary vascularity, unexpected findings, and extracardiac findings and complications, actually, for the diagnosis you have already made. So the approach you do is a bit different from what you see in the textbook. So in the next 15 minutes, what I would like to do is that really plain film made some clue to the important issues instead of going over all the chest x-rays. Just during this session, try to make your snap diagnosis when I show the films. So this is my approach to chest radiographs. If the chest x-ray was taken for heart disease, of course, I need to look at the ID and the sex and age, and also importantly, radiographic projections and technique. And if it is a first chest x-ray, I want to look at the abdomen first to decide whether situs is normal or abnormal, and then define the heart position, and then aortic arch position, giving the big picture, and then look at the heart size and configuration, and then, very importantly, pulmonary vascularity. The normal or increase or decrease or pulmonary edema or pulmonary arterial hypertension, and lastly, very importantly, uneven, unequal, asymmetric vascularity. And then also look at the contour of the aorta, superior vena cava and inferior vena cava. And then we need to look at the rest of the things too. So let me give you first the x-ray. A newborn with severe tachypnea arriving in the ER, and then have this chest x-ray. Heart is not large, and then you see that both lungs reasonably reticular, and then usually a little bit hyperinflated. And then the patient presenting symptom is tachypnea. And we all know that the first diagnosis is obstructed TAPVC, infradiaphragmatic type. I want to emphasize that that is not the only one. Whenever you have a severe obstruction, you have the same X-ray finding. So what it is the obstructive TAPVC. It doesn't matter whether it goes to the abdomen or to the brachiocephalic vein. If it is severely obstructed, you have same finding. And the second is that if you have a hypoplastic left heart syndrome with intact atrial septum or restrictive atrial septum, you have same finding. And then also viral pneumonia and lymphangiectasia can show similar findings. So those are the differential diagnoses. This is another case, 9-day male with the enteroviral sepsis and DIC. Almost identical finding. You have a severe pulmonary edema or interstitial pneumonia. Heart is a little bit big. So this is 13-day of life, and then follow-up is 20 days. The cardiac function is declining every day. Do you see anything here? A little bit different from 13 days and 20 days. And then follow-up, 2 days later. Do you see something here, unusual opacity? Okay. The following day here, you can see curvilinear calcification here. In retrospect, actually, there is one here, another here. So this is the myocardial calcification. We see that from time to time, especially in the kids having enteroviral infection. It is reported in the literature too. So my message to here is that if you see some opacity overlying the cardiac silhouette, that is a significant calcification. That should not be ignored. Okay? So this is another case with enterovirus. 5 weeks of life, you can see massive calcification here. Don't shy to say it is calcification of the heart. Okay? And 13-year female with chest pain, and the patient had the surgery for ARCAPA. So this is the primary, this is the follow-up. a little bit chest pain. So here you see that very rapid change in cardio-pericardial silhouette. The other finding actually here is that heart margin is too sharp. So which means that cardiac pulsation is not transmitted right. So this is a typical development of pericardial effusion, which you don't want to miss. And this is 10-year male status post tetralogy repair. Do you see anything? So heart is mildly enlarged, and then you see that pulmonary vascularity actually is asymmetric. I emphasize chest X-ray is excellent in finding asymmetric pulmonary vascularity. You can see region by region. So right side is more prominent, left side less prominent. And then the hilar pulmonary vessel larger and smaller. And here periphery is much quieter here. And then this is the MR angiography. You can see left pulmonary artery is much, much smaller than the right pulmonary artery. Also, the asymmetric pulmonary vascularity, actually chest X-ray is excellent. So in your follow-up, you see that the asymmetric vascularity, especially in tetralogy follow or other conditions that can develop pulmonary artery stenosis, don't ignore this finding. And this is another interesting case. The patient is 2 years old and complex history of the cardiac manifestations and increased work of breathing. And then the patient has a history of VSD and the closure at the age of 5 months. And then patient is developing increased work of breathing. Okay, so this is chest X-ray. Do you see anything? So here you can see that the mild residual cardiomegaly, and then you have a little bit of pleural effusion on the right side here. And then if you look at the lung field, this side is far more reticular than the other side. And then you can see the vessel size actually larger in the left lung than in the right lung. So these two findings are very important too. What it is here is that this is the case with the complete obstruction of right pulmonary veins. If the patient develops pulmonary vein obstruction, ipsilateral, you develop the interstitial pulmonary edema. Very importantly, if you have your one-side pulmonary vein obstruction, pulmonary blood flow is diverted to the other healthy side. So you have your increased pulmonary vascularity on the left side and decreased vascularity on the right side, but interstitial edema. So this chest X-ray really needs to should lead to the diagnosis of unilateral pulmonary vein obstruction. So very annoying here is that pulmonary vein obstruction actually substrate might have been present at the time of birth, but however, manifestation can be later. So we have seen multiple cases having surgery for congenital heart disease, usually minor, so the VSD, ASD, or PDA, in a couple of months or weeks develop pulmonary vein stenosis. In that regard, plain film finding actually is quite important. That should not be ignored. So this is the long time I have been experienced a misdiagnosis, 7-year-old boy with dyspnea, and the patient can have hemiparesis. And then what you see here is that dextrocardia? No, it's not dextrocardia. Why? You have airway all displaced to the right side, which means that right side of the lung is small or left side of the lung is large, and heart is displaced to the right side. I have seen multiple cases. The patient has been on the antibiotics for years, and then it's just to come and go. And then the diagnosis of this is actually absence of mediastinal segment of the right pulmonary artery here, so-called the ligamental ductal origin of the right pulmonary artery, which means that, so small pulmonary artery at the hilum, actually it is attached to the base of the brachiocephalic artery, which means that there is a ligamentum ductus arteriosus here. So differential diagnosis of right lung hypoplasia, small lung, ligamental ductal origin of the right pulmonary artery as I shown you, unilateral right pulmonary vein obstruction, scimitar syndrome well known, and then if you have none of this and you begin to think about hypoplasia of the right lung. In children, you also need to include in the differential diagnosis the hyperinflation of the left lung due to foreign body aspiration. So this is another case with the right lung, decreased vascularity again because of unilateral atresia of right pulmonary vein. You have decreased vascularity, increased vascularity, chronic obstruction, you have your right lung smaller and smaller. So those findings are also very similar to unilateral absence of right pulmonary artery. But in this case, that I don't see much interstitial densities, but in this case, pulmonary vein wasn't a problem. Scimitar syndrome, I don't want to go over, so because the Scimitar syndrome, you have variable degree of right lung hypoplasia. In this case, that you have vertical vein there, so you can see that the Scimitar vein is pretty well known. I don't want to spend much time there. So this is a 15-year-old girl with intermittent chest pain and dyspnea on exertion. I don't know what it means by ECG. ECG description is T-wave inversion and QRS axis at 90 degrees. So do you have any snap diagnosis of this case? So differential diagnosis of chest X-ray is one thing, and then the other is that pectus excavatum. The heart is displaced to the left side, but in lateral view, sternum is okay. If we have this finding, you should make the diagnosis over here. So what it is in MRI and CT, findings are very, very subtle. What it is the heart is displaced to the left side significantly. This is the telltale sign. Between the main pulmonary artery and ascending aorta, lung tissue is herniating into this space. Normally, pericardium covers this space, and the lung tissue cannot be there. So this means that the absence of pericardium, and then I'm going back, this plain film finding is very, very, very typical. So if it is not pectus excavatum, it is absence of pericardium, almost always. So a teenager with chronic dyspnea on exertion, this patient actually history was that the patient didn't like a gym class at the school, but the student was forced into the gym class and collapsed. But this is a chest X-ray. So what you have is that main pulmonary arterial trunk is very large, heart is moderately enlarged, retrosternal clear space is obliterated. So this finding, you have a rather big central pulmonary arteries. In the frontal view, you don't perceive that much, but if you look at the lateral view, trachea is coming down. This is a right upper lobar bronchus. This is a left upper lobar bronchus. This is mostly left pulmonary artery. This is mostly right pulmonary artery. Right and left pulmonary arteries make a big lump at the hilum. I call this potato with this small sprouts coming up. This is typical central peripheral discrepancy. You need to understand if the patient didn't visit to you, and then pulmonary hypertension diagnosis can be later. And then if you have this chest X-ray, it can't be normal. It's typical pulmonary arterial hypertension. So the reason why you have bulging is that the main pulmonary artery is very large. In the lateral view, you can see central pulmonary artery, main pulmonary artery very large, and the left pulmonary artery, which is equivalent to here, equivalent to here. So another one is that this is also a very important one. A teenager with known diagnosis of pulmonary hypertension. No. Chest X-ray finding a little bit different from the previous one. Very similar. Very large main pulmonary artery, but a little bit reticular at admission. Because of the given diagnosis, known diagnosis, the patient was given oxygen and the vasodilator, and then this is a follow-up. You have worsening pulmonary edema, severe pulmonary edema in a couple of hours. What it is that in CT scan, you can see increased reticular pattern everywhere, and then you have mosaic pattern of densities. So this is typical pulmonary veno-occlusive disease. So the major problem is that this is the idiopathic pulmonary hypertension. This is pulmonary hypertension secondary to pulmonary veno-occlusive disease. Given the fact that here it is a venous occlusion, your vasodilator might not work, can make things worse. So that's why the differential diagnosis is helpful in your patient management. So the 16-year-old male with Crohn's disease and hypertension, very simple finding. Descending aortic contour is very wavy and prominent. So this is very typical finding of Takayasu arteritis. Okay. So another case, you can see that very large lump here. It could be either mediastinal tumor or is a dilated descending aorta. So in this case, this is another Takayasu arteritis. I have an experience in the 20-year-old lady having similar finding, and then the patient was on the schedule for surgery for coronary artery bypass. And then we see that calcification here, and that is another Takayasu arteritis. So 4-year-old with a child with AVSD, the patient, they had a surgery, so this is a follow-up. Okay, so you see that the superior mediastinum is very, very wide after surgery. There are two chances. One is that normal thymus can have a very big rebound growth in a couple of days, and then you can have a very large superior mediastinum. But in this case, don't ignore that that can be due to this kind of large fluid collection of hematoma. So this is the another case with the 8 months with the double artery right ventricle, ASD and stenting. So this is true story. The patient had a significant cardiomegaly, but however, I see a little bit of two loosened structures there, tubular or linear or whatever. And then that finding also should not be ignored. What it is that this is the early sign of interstitial emphysema. So just the 1 day after, you have your pneumothorax developed and an obvious interstitial, the pulmonary emphysema here. So going back to the original slide, steps in chest radiograph that I recommend is with first study, go for these steps if it is for cardiac indications. Okay. So, and then what you really don't want to miss, I listed was interstitial edema versus infection. Chest X-ray is very good. Unusual contour and calcification, etc. Asymmetric pulmonary vascularity, the X-ray is excellent actually. And the pulmonary hypertension and pulmonary veno-occlusive disease. In adult it is very difficult because a lot of other causes of interstitial density, so-called idiopathic interstitial fibrosis type of things. But in children, if you have a prominent interstitial densities and findings of pulmonary hypertension, that is almost always pulmonary veno-occlusive disease. Rapid change in cardiac silhouette size and configuration should give you some alert, and abnormal area in the lungs and mediastinum. Thank you very much for your attention.